What if the prediabetes isn't just a quiet warning, but actually a stage where serious, maybe irreversible complications are already starting, especially when we talk about vision? Welcome to the Deep Dive. Today we're undertaking, well, a critical mission to fundamentally reshape how we, as specialist endocrinologists, view prediabetes, particularly its surprising connection to diabetic retinopathy. We're going to extract the most important insights from the latest research, the clinical guidelines, equipping you with the knowledge needed to proactively identify, understand, and manage these early ocular changes in your prediabetic patients. It's really all about helping them preserve their vision. To do this, we'll be drawing from key sources like the ADA Standards of Care 2024, findings from the Long-Term Diabetes Prevention Program, Outcomes Study, the DPPOS, and insights from leading ophthalmology and even health tech publications. Okay, let's really unpack this then. The very idea that eye damage can happen before a full diabetes diagnosis is, well, it's startling, isn't it? It challenges our kind of traditional understanding of prediabetes as just a risk factor. So what's the most compelling evidence that truly reshapes how we should think about this early progression?
It is fascinating, how we often see prediabetes as this sort of benign waiting room before the actual disease kicks in. But the evidence, it really shows it's a dynamic metabolic continuum. Microvascular changes, particularly retinopathy, they can absolutely initiate even when glucose levels are below that diagnostic threshold for diabetes. If we look at the clinical prevalence data, it paints a very different and, frankly, quite unsettling picture compared to just self-reported figures.
Different how? What are we seeing in clinical studies?
Well, for example, initial results from the Landmark Diabetes Prevention Program, the DPP, revealed that a significant 7.9% of participants who hadn't even progressed to diabetes still presented with retinopathy.
7.9% before developing diabetes.
Exactly. And the long-term follow-up in the DPP outcome study, the DPPOS, it continued to show substantial prevalence. We're talking 7.7% at 5 years and 8.7% 11 years among participants who stayed in the prediabetes category.
Hold on, nearly 8%, nearly 9% by 11 years
Yeah.
of people not progressing to full diabetes still had retinopathy. That's a really significant figure.
It is.
Does that suggest the traditional threshold for diabetes might not capture the full microvascular risk? It really redefines what pre means, doesn't it?
Precisely. It highlights this metabolic continuum perfectly. And look, these aren't isolated findings. Various cross-sectional studies back this up with reported diabetic retinopathy prevalence in pre-diabetic individuals ranging anywhere from 8.2% up to a striking 20.9%.
20%?
Yeah. The Gutenberg Health Study, for instance, found 8.2% with an HbA1c between 5.7 and 6.4%. Another study reported 20.9% in pre-diabetic subjects compared to literally 0% in controls. And the NANZAC Eye study found 10.4% with fasting plasma glucose just between 100 and 110 milligdl. So this isn't just theoretical, it's happening in our patients now.
Okay, so a significant percentage are already experiencing damage.
Yeah.
But what about the specific glucose levels? Are we seeing damage at levels we might consider, borderline or maybe even normal by some older standards?
That's the crucial point. Research indicates that the prevalence of retinopathy actually starts to increase at fasting plasma glucose levels as low as 117 milligdl.
117.
Yes, and HbA1c values below the current diagnostic cutoffs for diabetes, which are 126 milligdl and 6.5% respectively. Specific studies even show that a fasting glucose of 108 milligdl and a 2-hour post-load glucose of 162 milligdl can predict the appearance of retinopathy.
So even below the official prediabetes threshold for fasting glucose in some cases.
Right, and what's critical here is that there's a continuous increase in DR prevalence across the entire pre-diabetic HbA1c range that's below 6.4%. Now, the trajectory is shallower compared to when A1c hits 6.5% or higher, but the risk is clearly rising. It underscores that prediabetes is not a benign state for eye health. It's an active metabolic process needing our attention.
Wow, that truly makes you rethink that standard prediabetes conversation we have with patients. Okay, so if retinopathy can show up this early, what are the more subtle signs? Maybe even pre-retinopathy ocular changes that we as endocrinologists and our team should be listening for during patient interactions. It's clearly more than just looking for visible retinal damage on a fundus photo, right?
Absolutely. Beyond classical retinopathy, there's a whole spectrum of ocular changes linked to these metabolic shifts in prediabetes that you might pick up on or that patients might mention. One really significant indicator often overlooked is transient blurred vision,
Transient blurring. Tell me more about that.
Prediabetes can cause sudden or temporary blurring. This happens because of fluid shifts in and out of the eye's natural lens. The lens responds quite acutely to those fluctuating blood sugar levels. Think of it like the lens swelling or shrinking just slightly.
So a patient might complain their vision is suddenly off, maybe for a few hours, then it clears up. That's a great symptom to specifically ask about.
Precisely, and it's common. Approximately 1 in 4 adults with fasting glucose levels between 100 and 125 milligl report experiencing at least one episode of this temporary blurring. What's empowering for patients and for us clinicians is that controlling glucose, often within weeks, just stabilizing levels below 110 milligl, usually restores sharp vision.
That's quick.
It can be. Patients sometimes even notice their old glasses working perfectly again. It's a powerful motivator for them.
Definitely. Okay, beyond the lens, what else? You mentioned the anterior segment.
Right, the front of the eye. That's the cornea, tear film, ocular surface. These also show important changes. We see things like increased corneal thickness and stiffness. Central corneal thickness can increase by 10 to 30 microns, even in folks with controlled diabetes, and these changes are also seen in patients with impaired glucose tolerance and obesity.
And why does that matter clinically for us?
Well, for us, this increased thickness and stiffness, or hysteresis, it can lead to an overestimation of intraocular pressure when measured. This could potentially contribute to, say, glaucoma misdiagnosis, which is a critical point when you're referring to ophthalmology or interpreting their reports.
That's a crucial clinical detail. What about the corneal nerves? I mean, we think about peripheral neuropathy being a hallmark of diabetes. Does that extend to the eye surface too?
Excellent point. Yes, there's also reduced corneal innervation. Patients with prediabetes show reduced subbasal nerve length, density, and branching. And this directly correlates with diabetic peripheral neuropathy.
So nerve damage on the eye surface itself.
Exactly. And this reduced sensitivity can impair corneal wound healing and also reflex tear production. This can lead to issues like chronic dry eye, superficial punctate keratitis, those little erosions on the surface, or even recurrent corneal erosions. It's often subtle, but patients might complain of persistent irritation, maybe a feeling of grittiness they can't shake.
Things we might normally just attribute to dry eye without thinking about the underlying metabolic state.
Potentially, yes. Additionally, we can see an altered corneal immune response with more epithelial dendritic cells in prediabetes. This might lead to a prolonged or exaggerated immune response to infections or inflammation. And yes, tear film and meibomian gland dysfunction are very common. You might see faster tear breakup time, decreased tear production, higher tear osmolarity.
So more symptoms of dry eye, perhaps worsening, or maybe unusual glare, changes in light perception, all could potentially link back to these corneal and tear film changes.
Exactly. These are subtle but critical signs we might miss if we're not specifically attuned to them in our pre-diabetic population.
Okay, those are the subtle signs. But are there any red flag vision changes that mean we need to get the patient to an ophthalmologist urgently, even if they're only pre-diabetic?
Yes.
Because that's where early intervention can truly save sight.
Absolutely. And these are crucial for you to educate your patients about. Emphasize these are not symptoms to ignore or wait out. If a patient reports seeing wavy straight lines like looking at blinds or tiles, that's a classic red flag for macular edema, swelling right at the center of the retina.
Which affects central vision directly.
Critically, untreated, it can quickly lead to irreversible central vision loss. Urgent referral needed. Also, sudden loss of a visual field, maybe like a dark curtain falling, or missing areas in their vision that can indicate a paretinal hemorrhage, bleeding right in front of the retina, needs same-day ophthalmology review, no question.
Okay, same day. What else?
Flashes of light, a sudden shower of new floaters, or maybe spiderweb shapes drifting in their vision. These suggest vitreous traction, the gel inside the eye pulling on the retina.
Which can lead to detachment.
Precisely. It can precede a retinal detachment. A prompt dilated examination significantly reduces the risk of permanent vision loss there.
So immediate, potentially sight-threatening changes. Anything else on the urgent list?
Yes, a persistent haze that isn't relieved by blinking. This might be corneal edema from severe hyperglycemia. It can progress to pain and scarring if glucose stays high. While it's rarer in prediabetes, eye pain combined with blurred vision could signal acute angle closure glaucoma. That's an emergency needing immediate care to prevent optic nerve damage. And one more, blurred vision that persists after treating low blood sugar. That's also an emergency sign. Could be a rebound effect or something else critical going on.
So the crucial takeaway for us as endocrinologists is?
Look, given that nearly 8% of people can already show diabetic retinopathy while still technically in the pre-diabetic stage, Any new or concerning blur in vision warrants a same-week dilated eye exam. We simply cannot wait for a formal diabetes diagnosis.
That's a powerful call to action. Okay, this is where it gets really impactful for our practice. We know these risks exist, even in prediabetes. So what can we do? As endocrinologists, with our multidisciplinary teams, how can we proactively prevent or manage retinopathy and these other complications? This feels like where our specialist knowledge really comes into play, shifting from just observation to, well, more aggressive intervention.
Exactly. If we connect this to the bigger picture, the whole emphasis shifts dramatically. It's not just about treating established diabetes anymore, it's about aggressively managing prediabetes, especially given this potential for early, sight-threatening eye complications. The ADA guidelines strongly reinforce the importance of not just good glucose control, but also meticulous management of blood pressure and cholesterol. These are systemic factors that we, as endocrinologists, are uniquely positioned to influence.
Right. Multifactorial approach. Let's break that down. Glycemic control first.
Okay. Encourage regular patient monitoring. Just checking fasting glucose at least twice a week, aiming for morning readings under 100 milli-GDL. That simple step correlates with a significant 40% lower odds of developing diabetic retinopathy over 5 years.
40% lower odds. That's huge from just monitoring fasting glucose.
It's a massive impact. And utilize HbA1c effectively. If that A1c starts trending above 6.0%, closer follow-up is definitely warranted. Remember, retinal changes become detectable in roughly 15% of patients at that threshold. Quarterly A1c testing in this context gives timely feedback for adjusting diet, exercise, maybe medication.
And speaking of medication, what about pharmacological intervention at this prediabetes stage? We usually think of metformin for full diabetes, but your evidence suggests maybe we need to be more proactive.
Exactly right. We should consider pharmacological intervention more readily. Observational data linked initiating metformin in prediabetes with a substantial 35% reduction in new onset retinopathy over 3 years.
35% reduction in retinopathy with metformin in prediabetes.
Yes. So it makes it a very reasonable, individualized treatment consideration we shouldn't shy away from discussing. Furthermore, we know that regression to normal glucose regulation, getting people out of prediabetes, results in a 56% reduction in actually developing diabetes, and critically, a reduced risk of retinopathy. This isn't just about preventing diabetes down the line, it's about protecting organs now.
Protecting organs now. I like that framing. Okay, beyond glucose, blood pressure.
Absolute crucial. Emphasize strict blood pressure management. Aim for levels below 130/80 millimillimeter Hg. Why? Because hypertension can literally double the risk that existing pre-diabetic retinal changes will worsen within just 1 year.
Double the risk. Wow.
Think about ACE inhibitors too. Even mildly elevated pressures, say 135/85, respond well to low-dose ACE inhibition. It's been shown to cut microaneurysm formation by a third. Lowering blood pressure consistently decreases retinopathy progression. It's a pillar of management.
Okay, so tight BP control. What about lipids?
For lipid management, addressing dyslipidemia is non-negotiable. High triglycerides specifically seem to accelerate retinal capillary leakage, so aiming for levels under 150 milli-GL is important. There's even evidence that adding fenofibrate might slow retinopathy progression, particularly in cases with very mild, non-proliferative diabetic retinopathy at baseline.
Interesting. And the basics.
Don't forget the basics: smoking cessation. Current smoking is identified as a significant modifiable risk factor for developing DIR. We have to address that with every single patient.
So it's this truly holistic, multi-pronged approach to metabolic control, not just glucose, which makes perfect sense given the systemic nature of these microvascular issues. What about ongoing eye surveillance and referrals? Because this is where our collaboration with ophthalmology is key.
Absolutely paramount. An annual dilated eye exam is essential. Even before a diabetes diagnosis, we can't wait for them to hit that 6.5 A1C.
Start annual exams based on prediabetes diagnosis.
Yes. Remember, the research shows 8% of people with an A1C between 5.7 and 6.4 already have microaneurysms. If DR is found on screening, prompt referral to an ophthalmologist knowledgeable and experienced in its management is unequivocally recommended, no delay. And a special note here. For individuals of childbearing potential who have pre-existing type 1 or type 2 diabetes, if they're planning pregnancy or are already pregnant, intensive counseling is crucial.
Why specifically?
Because the risk of DR development and/or progression during pregnancy is high. Reported prevalence rates are over 50%, with significant progression often seen. Close follow-up must be maintained with ophthalmology throughout pregnancy and postpartum to prevent vision loss.
That's a really important point for managing that patient population. Okay, and if retinopathy is detected, what are the treatments we should generally be aware of so we can set the right expectations when we refer?
Excellent question. So you'll probably refer anyone with any level of diabetic macular edema, DME, moderate or worse non-proliferative diabetic retinopathy, NPDR, or any proliferative diabetic retinopathy, PDR. The good news is the current treatments are highly effective. They include laser therapy like panretinal laser photocoagulation, or PRP. PRP is indicated to reduce vision loss risk in high-risk PDR and sometimes in severe NPDR. There's also macular focal or grid photocoagulation as an option for persistent DME.
So laser's still a major tool, but what about the newer treatments, the injections?
Yes, and anti-VEGF injections have really revolutionized treatment over the last decade or so. Intravitreal injections of antivascular endothelial growth factor agents, things like aflibercept, ranibizumab, bevacizumab is used off-label, brolucizumab, faricimab. These are now often first-line treatment for most eyes with center-involved DME that impairs vision. They're also a reasonable alternative to laser for some cases of PDR. While they're incredibly effective, the downside is they may require more frequent visits than laser therapy.
More frequent visits, but potentially better outcomes or faster resolution in some cases.
Potentially, yes. And critically, anti-VEGF treatment, even for non-proliferative diabetic retinopathy, has been shown to reduce the later development of retinal neovascularization in DME. So it can be preventative, too.
And corticosteroids.
Yes, corticosteroids injected intravitreally are a reasonable option for eyes with persistent DME, despite trying anti-VEGF therapy first, or for individuals who aren't candidates for anti-VEGF, maybe during pregnancy, for instance.
Okay, that gives us a good overview of the ophthalmologist's toolkit. So bringing it all together, what does this mean for us, the endocrinologist, in our day-to-day practice? It really seems like a deeper, more integrated focus on eye health within our general prediabetes, and diabetes management isn't just beneficial, but absolutely essential.
It really highlights the necessity of a truly multidisciplinary approach, doesn't it? Endocrinologists are often on the front lines for prediabetes diagnosis and management. So your awareness, your proactivity regarding these early ocular changes, it's paramount. A key component here is patient empowerment through education. Things like online patient-directed education can empower individuals to proactively engage with both you, their primary diabetes care provider, and their eye health providers.
Making them active partners.
Exactly. Many participants in studies were initially completely unaware of DR as a diabetes-related eye condition before their own diagnosis. They often found out during a routine eye exam. Education reinforces why glucose monitoring matters, why BP control matters for their eyes. We also need to bridge those communication gaps. Patients often report that their healthcare providers never discuss it at all, or don't tell me anything special, specifically about diabetic retinopathy, maybe just due to lack of time.
We're all pressed for time, that's true.
Right. But educational initiatives, even brief ones, can help patients formulate specific questions about their condition, their risks, their treatments. It fosters a better dialogue with specialists like yourself and with the ophthalmologist.
That's a huge point. Patients can't ask the right questions if they don't even know what they should be thinking about. What about technology? Can that help here?
Technology's role in surveillance is growing fast.
Right.
AI-powered health insights, like those from Eureka Health, for example, can support patients with real-time symptom triaging.
Like what?
Like prompting an urgent care referral if they log symptoms like slashes of light, or automating prompts for glucose checks when they log an episode of blurred vision, even reviewing their medication list for potential ocular side effects. Users in some studies found that just seeing a graph of their blurred vision episodes overlaid with their glucose spikes motivated adherence much more effectively than just being told to control their sugar.
That visual connection is powerful.
Incredibly powerful, that real-time personalized feedback. And while our deep dive today focused specifically on retinopathy, it's vital we recognize its shared risk factors and management strategies with other diabetes complications. It's all interconnected.
How so?
Well, for instance, the presence and severity of retinopathy is actually a factor used in assessing risk for diabetic foot ulceration. And optimizing systemic factors like blood pressure and lipids doesn't just impact eye health, it impacts neuropathic complications, kidney disease, cardiovascular risk, overall well-being.
Right. Managing the patient holistically always makes sense.
Always.
We've really unpacked today how critical it is to look beyond just the prediabetes,
Yeah.
to recognize that significant microvascular changes, especially in the eyes, can already be underway, impacting vision and quality of life in ways we might have previously underestimated.
Indeed. So the question for you, the specialist endocrinologist listening, is no longer if prediabetes impacts ocular health. We know it does. The question now is how effectively can we as a healthcare community integrate these crucial early insights into our routine practice? How can we truly shift from being reactive treaters to proactive preventors for our patients' long-term vision and their overall well-being? Maybe think about just one immediate shift you can make in your practice starting tomorrow to better serve your pre-diabetic patients and help safeguard their sight for the years to come.